Today we will study about pain pathways and mechanisms of pain relief. At the end of this lecture, the student will be able to define what is pain and what are the types of pain. The student can tell about the pain processing and the pain pathways, which includes the ascending and descending pathways and the pain inhibitory mechanisms. The student will also learn about central sensitization and the principles of pain management, which includes medications, nerve blocks, and other techniques. Now, what is the definition of pain? Pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. This definition has been given by International Association for the Study of Pain in January 2020. This has been revised for the first time since it was first given in 1979. In this definition of pain, it is expanded upon by addition of six keynotes, which includes pain is always a personal experience that is influenced to varying degrees by biological, psychological, and social factors. Pain and nociception are different phenomena. Pain cannot be inferred solely from activity in sensory neurons. Through their life experiences, individuals learn the concept of pain. A person's report of an experience as pain should be respected. Although pain usually serves an adaptive role, it may have adverse effects on function and social and psychological well-being. Verbal description is only one of several behaviors to express pain. Inability to communicate does not negate the possibility that a human or a non-human animal experiences pain. Pain is always subjective. It is a sensation in parts of the body. It is unpleasant and has emotional and psychological components. In chronic pain, no actual tissue damage or cause is found, but pain resembles as it is caused by tissue damage. Now, what is nociception? Nociception is the neural process of encoding noxious stimuli. It is the neurophysiological activity in peripheral sensory neurons, the nociceptors, and higher nociceptive pathways. Nociception is not synonymous to pain. Pain is much more than simply activity in sensory neurons. Now, pain can be classified in various ways as acute and chronic, malignant and non-malignant. Let us come to the classification of chronic pain. The American Society of Anesthesiologists define chronic pain as extending in duration beyond the expected temporal boundary of tissue injury and normal healing and adversely affecting the function or well-being of the individual. It is also defined as pain without apparent biological value that has persistent beyond the normal tissue healing time, usually taken to be 3 months. For the first time in 2019, pain was included in ICD-11. Let us come to malignant pain. It occurs due to cancer, and cancer pain occurs due to tissue invasion of tumor in pain-sensitive structures such as pleura, peritoneum, which have primary afferent neuron innervation. Tumor can directly invade a peripheral nerve plexus. In such cases, neuropathic symptoms predominate. Treatment therapies for cancer can be associated with severe pain such as painful mucositis caused by radiotherapy and chemotherapy. Non-malignant pain can be inflammatory, musculoskeletal, neuropathic, and some other varieties. We will come to that. Inflammatory pain can occur due to arthritis or chronic inflammatory states. Musculoskeletal pain is like low back pain, and neuropathic pain includes postherpetic neuralgia, complex regional pain syndromes, and other neuropathies. Neuropathic pain manifests as lancinating, shooting, or burning pain, and it may be associated with hyperalgesia and allodynia. Non-malignant pain can also be post-traumatic pain, orofacial pain, or visceral pain. Post-traumatic pain is the persistent pain which develops after a tissue trauma such as surgery or accident. Orofacial pain or headaches. This category contains persistent headaches and orofacial pain such as dental pain. Visceral pain is caused by visceral inflammation or other factors causing visceral pain. Pain can be roughly divided into two broad categories, like the physiological pain and the pathological pain. Physiological pain is with a physiological phenomena, and obviously it is protective. It helps in survival by protecting the organism from further injury. It is usually acute and nociceptive, whereas pathological pain is a manifestation of alterations and maladaptations in the nervous system, such as neuropathic pain. Here, in pathological pain, the pain becomes a disease. Physiological pain is mediated by a sensory system consisting of the primary afferent neurons, the spinal interneurons, and ascending tracts and the supraspinal areas. We will come to the pain pathways in a while. First, let us see what are the major pain processes. There are four major pain processes which include transduction, transmission, modulation, and perception. Transduction is the activation of nerve endings by noxious stimulus. Transmission is a relay of message from nerve endings at the site of noxious stimulus to the brain. Modulation is a neural process which helps in modifying or reducing pain transmission. Perception is a subjective awareness of pain and is a complex process resulting from integration of several sensory neural messages. Now let us come to the pain pathways. There are two main pain pathways, the ascending and descending pathways. These are basically the routes of signal transmission. Ascending pathways means the route of signal transmission from periphery via spinal cord to the brain. Descending pathways, they transmit the nerve signal transmission from brain to spinal cord and other reflex organs. Ascending pathways include the sensory neurons in dorsal root ganglia. These enter the spinal cord via the dorsal roots. Pain and temperature fibers are present in the lateral-most dorsal roots. A delta and C fibers innervate the neurons in rexid lamina 1, 2, and 5. Rexid lamina 1 and 2 are also known as marginal zone and substantia gelatinosa respectively. These fibers cross the midline and ascend to thalamus in the anterolateral spinal cord. These fibers form the spinothalamic tract, and this spinothalamic tract is the major ascending pathway for information about pain and temperature. The spinothalamic tract sends collaterals to the hypothalamus and the limbic system. The spinothalamic and the spinoamygdalar pathways mediate affective and autonomic responses associated with pain, such as fear, anxiety, depression, tachycardia, hypertension, and endocrine stress response. These regions might also participate in antinociception. We will see that in the pain inhibiting mechanisms. Now, pain is further mediated by the thalamocortical projections to the somatosensory cortex. Perception of pain and integration of sensory, discriminative, and affective components of the noxious stimulation takes place in higher cortical structures, such as in supraspinal structures like primary and secondary somatosensory cortexes, anterior cingulate gyrus, the insula, and the prefrontal cortex. This is the pain pathway. Here we can see the dorsal root ganglion. This is the first order neuron. It synapses in the posterior cord. Then here comes, it crosses over, comes to the anterolateral part of the spinal cord, travels up as the spinothalamic tract. Here again it synapses and then forms the third order neuron, the thalamocortical projections, which goes to the cerebral cortex. So this is the pathway. The dorsal root ganglion gives rise to the A delta and C fibers. These fibers innervate peripheral tissues such as skin, muscles, joints, and viscera. A delta and C fibers transduce noxious or high threshold stimulus from free nerve endings and transmit them to the spinal cord. These nociceptors are polymodal. These transduce various modalities of noxious stimuli such as chemical, thermal, electrical, and mechanical. A delta and C fibers respond to noxious stimulation with slow adaptation and residual firing following the withdrawal of the stimulus. A delta fibers are lightly myelinated, medium diameter, rapidly conducting and produce pain, which is sensed as the first pain or the epicritic pain. This pain is sharp and well localized, whereas the C fibers are unmyelinated, small diameter, slow conducting, and these mediate the second pain or the protopathic pain. The pain is dull and poorly localized and appears temporarily following the first pain. Normally, A beta fibers transmit the mechanical responses and touch, but under chronic pain situations, A beta fibers can also transmit pain. This action of A beta fiber is the underlying mechanism for pain-relied transcutaneous electrical nerve stimulators. Very interestingly, tyrosine kinase protein A is a component of nerve growth factor receptor, and mutations in this gene leads to failure in development of A beta, A delta or C fibers, and these patients cannot sense pain. Now let us see the pain mediators. Damage to peripheral tissue by thermal, mechanical, chemical agents. They release the mediators such as glutamate, neuropeptides such as calcitonin, gene-related peptide and substance P, and pro-inflammatory cytokines. It leads to sensitization or direct activation of primary afferent neurons, the nociceptors. That leads to opening of cation channels in the neuronal membranes, capsaicin, proton and heat-sensitive transient receptor potential valenoid 1, or the ATP-gated purinergic P2X3 receptor. This gating produces an inward current of sodium and calcium ions into the peripheral nociceptor terminal. That leads to activation of voltage-gated sodium channels, leading to membrane depolarization and generation of action potential and leading to conduct to dorsal horn of spinal cord. Nociceptors to spinal neurons to the brain transmission is mediated through direct monosynaptic contact or through multiple excitatory or inhibitory interneurons. Now, the central terminals of nociceptors contain excitatory transmitters such as glutamate, which is a very important excitatory transmitter which activates the postsynaptic NMDA receptors, substance P, which activates neurokinin, and neurotrophic factors which activate tyrosine kinase receptors. Now let us see what is central sensitization. Repeated stimulus leads to nociceptive system sensitization, resulting in amplification in response and reduction in activation threshold as compared to normal noxious stimulus. It leads to temporal, spatial, and threshold changes in pain sensation. What is activity-dependent plasticity? It occurs due to repeated nociceptive stimulation that sensitizes the peripheral and central neurons. Now, wind-up is an interesting phenomena, which is a progressive frequency-dependent increase in the output in response to persistent nociceptor excitation in spinal neurons. Transcriptional changes in gene expression for neurotransmitters and receptors and other molecules can lead to sustained sensitization. Examples include NMDA receptors and COX-2 receptors. Let us come to three important phenomena: allodynia, hyperalgesia, and secondary hyperalgesia. Allodynia is defined by IASP as pain due to a stimulus that does not normally provoke pain. It is a heightened sensation to stimuli and reduction in stimulus threshold to be perceived as noxious, such as, for example, the touch of a feather can be perceived as painful in patients having allodynia. How is it different from hyperalgesia? Hyperalgesia is an exaggerated response from a normally painful stimulus. There is an enhanced pain sensitivity, and even light pressure can be perceived as very painful in hyperalgesia. So the main difference is in allodynia, stimulus which does not normally produce pain leads to pain, whereas in hyperalgesia, a stimulus which is normally painful produces an exaggerated response to pain. Now, secondary hyperalgesia is said when the pain spreads beyond the site of injury. Central sensitization, initiation and maintenance depends on peripheral nociceptor stimulation, and Therefore, management strategies targeting peripheral nociception can be helpful in chronic pain syndromes. Now let us come to pain inhibitory mechanisms. First time in 1965, endogenous mechanisms which counteract pain were described in the gate control theory of pain. There are peripheral mechanisms and central mechanisms. So the peripheral pain inhibiting mechanisms, what happens is whenever there is an inflammation of peripheral tissue, it leads to increase in opioid receptors in the dorsal root ganglion neurons. There is an increased accumulation of opioid peptide containing immune cells in the inflamed tissue. Basically, in response to inflammation, stress, and in the presence of releasing agents, the leukocytes can secrete opioids, and these opioid containing leukocytes reach the inflamed tissue guided by chemokines and adhesion molecules and secrete opioids. Even endogenous opioid production is upregulated whenever there is an inflammation of the peripheral tissue. Now these opioids can activate the peripheral opioid receptors, and which can lead to inhibition of nociceptor excitability, and it also inhibits the release of excitatory neuropeptides. Clinical application of these mechanisms is seen by the use of intra-articular naloxone to enhance analgesia after total knee replacement surgeries. Now, what are the central pain inhibiting mechanisms? In the spinal cord, there are interneurons, and these interneurons, they release the opioids, GABA and glycine. This release of opioids, GABA and glycine can activate the presynaptic opioid and GABA receptors on central nociceptor terminals, and it can reduce excitatory transmitter release. Also, these opioids, GABA and glycine, can evoke inhibitory potentials in the dorsal horn neurons. Moreover, at the level of interneurons, ongoing nociceptive stimulation leads to upregulation of opioid gene expression and its production. All these together leads to pain inhibition at the central level at the spinal cord. Now let us see the descending inhibitory pathways. Now descending inhibitory pathways travel from the brainstem to the dorsal horn. There is an important triad of regions mediating central inhibiting mechanisms, which include periaqueductal gray, rostroventral medulla, and dorsolateral pontine tegmentum. It functions through noradrenergic, serotonergic, and opioid system. Nociceptive reflex behavior suppression is mediated by axons of RVM neurons. These fibers descend within the dorsolateral funiculus and terminate bilaterally in laminae 1, 2, 5, 6, and 7 of the spinal cord. So here we see from the cerebral cortex to the thalamus to the midbrain, that is the periaqueductal gray, to the RVM of the medulla and to the dorsal horn. This is how the inhibitory mechanisms travel. Now let us come to the management of pain. Pain management should be multi-speciality, including pain management physician, psychologist, physiotherapist, and occupational therapist. We should not just cure pain. Overall rehabilitation should be the aim in pain management. We know that chronic pain is caused by an interaction of biological, psychological, and social factors. Biological such as tissue damage, psychological such as cognition, memory, and conditioning, social factors such as attention and reinforcement. Effective pain management programs must be multimodal and address this biopsychosocial model of pain. There are various pain management methods. One is medication, which we will discuss in a while. The other methods, apart from medication, include cognitive behavioral therapy. It addresses the maladaptive cognitive and behavioral patterns and helps patients actively participate in their recovery. Then the functional restoration, such as occupational and physical therapy, it helps patient in restoring the movements, body function, and improves the confidence. And the social support. These can affect pain intensity and issues such as financial, legal, employment, family support. These concerns should be addressed. Now we come to medications, and after medications we will also see the interventional pain management such as nerve blocks and other techniques. So in medications, we know that analgesic medications, they inhibit the impulse generation or impulse transmission causing pain. They act at the peripheral and central sites, and there can be various routes of different drug administration such as oral, intravenous, topical, subcutaneous, transmucosal, transnasal, intrathecal, epidural, intraarticular. So first of all, let us see a table which elaborates on the type of the group of the drug, their mode of action and their limitations. So first of all, let us see the opioids. They act on the mu, delta and kappa receptors. They inhibit the release of excitatory neurotransmitters and reduce neuron excitability. Their side effects include sedation, nausea, respiratory depression, euphoria, dysphoria, diuresis, constipation. Then we come to the serotonin agonist. They act on G protein coupled 5-HT receptors and inhibit release of excitatory neuropeptides, reduces inflammation. It causes vasoconstriction. Therefore, the side effect is myocardial infarction, stroke, and peripheral vascular occlusion. It should be used with caution in patients of MI, stroke, and peripheral vascular occlusion because it causes vasoconstriction. Then we come to the antidepressants. They act on the noradrenaline 5-HT transporters and sodium and potassium channels, causing reduction in neuron excitability. Their side effects include sedation, dryness of mouth, constipation, and cardiac arrhythmias. Then we come to the anti-epileptics. These block the sodium and calcium channels. They have GABA agonistic activity and they inhibit the release of excitatory neurotransmitters and reduce neuron excitability. Their side effects include somnolence, fatigue, cognitive impairment, and impaired motor functions. In high doses and in prolonged use of anti-epileptics, it can cause hepatotoxicity, thrombocytopenia, rarely. NSAIDs, the mode of action, it inhibits cyclooxygenases COX-1 and COX-2 and reduces the production of prostaglandins and thromboxanes. It reduces the sensory neuron sensitization and inhibits the spinal cords, the neurons. The limitations include gastrointestinal bleeding and perforation. COX-2 inhibitors can cause acute stroke, myocardial infarction, and thrombosis. Now, let us see the site of action of various analgesic drugs. Here, epidural anesthesia acts at the peripheral level. We have the local anesthetics and NSAIDs. Again, at the first order neuron, we have the epidural anesthesia and epidural steroid injections. Then, at the level of the spinal cord, we have local anesthetics. Then the opioids, they help in pain modulation, and systemic opioids and paracetamol also act at the central cortical level. Then we come to the alpha-2 adrenergic receptors. The examples include clonidine. It has an overall inhibitory effect. It is G protein coupled and it opens potassium channels, inhibits the presynaptic calcium channels and inhibits adenylyl cyclase. It reduces the neurotransmitter release and decreases the postsynaptic transmission. It is used in neuropathic pain syndromes and the side effects include sedation, hypotension and bradycardia. Cannabinoids, the receptors are present in brain, spinal cord and in periphery, and its limitations include sedation, dryness of mouth, cognitive impairment and psychotropic effects. Then we come to the other agents such as benzodiazepines and baclofen. Both of them reduce the muscle spasm. They are useful in musculoskeletal pain and muscle spasticity states. Baclofen activates both presynaptic and postsynaptic GABA B receptors, leading to a decrease in excitatory and an increase in inhibitory neurotransmission. Botulinum toxin, it inhibits the acetylcholine release at neuromuscular junction. Its side effects include drowsiness and dizziness. Then we come to ziconotide. It is a synthetic peptide. It blocks N-type voltage-sensitive calcium channels. It inhibits the release of excitatory neurotransmitters, and it is used via the intrathecal route and in intractable pain. Limitations of ziconotide use includes confusion, memory impairment, hallucinations, delirium, nystagmus, vertigo, apnea, and hypotension. Opioids. What is tolerance to opioids? Tolerance means that the drug effect decreases with repeated administration of the same dose of the drug. So increasing doses are required to achieve the same effect, that is tolerance. It is seen to all opioid effects of varying degrees, but least tolerance is seen to constipation and meiosis. Therefore, patients on opioids are chronically constipated and have meiosis. Now, what is physical dependence of opioids? This is the appearance of withdrawal symptoms on drug cessation or abrupt dose reduction. This effect can also be produced by administration of antagonist. Physical dependence is seen with all opioids, even in short periods of administration. Now, what is opioid rotation? Opioid rotation is sometimes used in improving pain relief or reducing the side effects by a particular opioid. So, a different group opioid is used in place of the primary opioid. This occurs due to genetic differences and incomplete cross tolerance between opioids. Now, what is opioid-induced hyperalgesia? It is production of allodynia in opioid users attributed to neuroexcitatory effects of opioid metabolites. But this lacks conclusive evidence. There is another phenomenon known as the withdrawal-induced hyperalgesia. It occurs following abrupt cessation of opioids, and it is a well-known phenomenon. Now let us come to NSAIDs and acetaminophen. Acetaminophen and NSAIDs such as indomethacin, diclofenac or ibuprofen, they are used in not so severe pain such as headaches. They are easily available. There is frequent drug abuse of this group of drugs and self-medication is done. They are not indicated in neuropathic pain. Adverse events include medication overuse headache, bleeding disorders, gastrointestinal ulcers, nephrotoxicity, and hepatotoxicity. Additionally, COX-2 inhibitors can cause myocardial infarction and thrombosis. Triptans, they are commonly used in the treatment of migraine. Migraine pathogenesis is related to release of neuropeptides from trigeminal neurons, causing vasodilatation of meningeal and intracranial vessel, leading to pain. Triptans reduce this inflammation and causes vascular constrictions via action of 5-HT1D and 5-HT1B receptors. The route of administration of triptans is oral, subcutaneous, and transnasal, and their limitations include because of arterial constriction via 5-HT1B receptors, these should not be given in patients at risk of coronary, cerebral, or peripheral vascular disease. Antiepileptics. They are commonly used in neuropathic pain and migraine prophylaxis. Antiepileptics can be sodium channel blockers such as carbamazepine used in trigeminal neuralgia, or calcium channel blockers such as lamotrigine or topiramate used in diabetic neuropathy. Examples of neuropathic pain include diabetic pain, herpes, and stroke. Limitations include somnolence, fatigue, cognitive impairment, and impaired motor functions. On high doses and prolonged use, hepatotoxicity and thrombocytopenia may develop. Now we also have some topical analgesics. There are various drugs which can be used as topical preparations such as NSAIDs like diclofenac, capsaicin, local anesthetics like lignocaine, opioids like fentanyl and buprenorphine, and antidepressants like tricyclic antidepressants, doxepin. These preparations act locally at peripheral nerve endings and mediate analgesia. They are commonly used in post-herpetic neuralgia, post-mastectomy pain, and neuropathic pains. Advantages include localized drug concentration at the pain generation site. Lower drug doses are needed. There are less systemic effects and less drug interactions. So after medications, we come to nerve blocks, which can be diagnostic and therapeutic. In diagnostic nerve blocks, the aim is to locate a pain source by blocking a specific nerve. Whereas in therapeutic nerve block, it helps as an adjuvant to medical treatment to improve the therapeutic effect or to reduce the side effects, or both. Nerve blocks can relieve pain and help in physical therapy and rehabilitation of the patient. Now, various nerve blocks are commonly administered in cancer patients, sometimes for non-malignant neuropathic pain also. Common sites include celiac plexus block, lumbar sympathetic ganglion, superior hypogastric ganglion, hypogastric plexus block, intercostal nerves, ganglion impar, thoracic intrathecal blocks, and intrathecal neurolysis. Now, nerve blocks, they can either be destructive or they can be non-destructive. Destructive nerve blocks include applications of alcohol, phenol, or radiofrequency ablation. There, the aim is to destroy the nerve, and it is done on trigeminal nerve branches, cancer, and for cancer pain. Whereas non-destructive nerve blocks, it involves the administration of local anesthetics, steroids, thermal rhizotomy of medial branch, and these are done at facet joints like epidural steroids, trigger point injections, intra-articular injections, sympathetic nerve blocks, and non-malignant conditions such as herpes zoster. Here, the aim is not to destroy the nerve but to just relieve pain by giving local anesthetics or by adding steroids or other medications or by doing thermal rhizotomy. Now, neuraxial techniques can either be single shot and repeated as per need, or they can be a continuous drug delivery system, such as intrathecal or epidural space. There are implantable pumps and tunneled catheters which are placed in these spaces. These can have a continuous drug delivery to central neuraxial spaces. They cause less side effects than the systemic therapy. The limitations of continuous drug delivery includes non-uniform analgesia, granuloma formation, some machine mechanical problems or infections at that site, and sometimes displacement of the pump or catheter. So basically this machine, it requires care. Now, for the sake of completion, there are some other techniques such as stimulation techniques like acupuncture, which is commonly used in migraine and arthritic pain, spinal cord stimulation. They are used in some types of intractable pain, the complex regional pain syndromes, and failed back syndromes. And we have the transcutaneous electrical nerve stimulation known as TENS. So in the end, I would just like to say pain is real, but so is hope. Thank you.